This presentation is on drugs that treat inflammatory processes. We're going to do this in two parts. So for this presentation, we're going to talk about corticosteroids, NSAIDs, and aspirin. And then part two, we'll discuss anti-gout and uricosuric agents as well as arthritis drugs. Cortisol is the endogenous glucocorticoid in the body, and it's produced and secreted on the basis of the feedback mechanism of the HPA axis. The adrenal cortex synthesizes and secretes the steroid hormones that include the mineralocorticoids, the glucocorticoids, and to a lesser extent, androgens. So cortisol can be considered the wake-up hormone. Altered levels of cortisol can change the degree of awareness, can change sleep patterns, as well as affect emotions. And high levels of cortisol, as we know, in times of stress, can stimulate gluconeogenesis, catabolism of protein, and even affect memory recall. So this diagram depicts the glucocorticoid feedback system. And you can see that in times of stress, such as hypoxia, hypoglycemia, or when cortisol is insufficient, this has a positive feedback on the pituitary to release ACTH that then acts on the adrenal cortex to synthesize and secrete the glucocorticoids and the mineralocorticoids. So exogenously administered adrenal cortex hormones like corticosteroids, when we prescribe them, also can have effect on this feedback mechanism. So this shows also the many actions of glucocorticoids in the body. And here they are. So we have numerous things that glucocorticoids can do. They can inhibit immune and inflammatory systems, increase erythrocytes, increase appetite, fatty deposition, especially in the face and the cervical areas. They can promote lipolysis in the extremities and increase uric acid excretion. They decrease serum calcium levels, so that has an effect on bones as well as causing skeletal wasting. They promote gastric acid secretion. Numerous things that glucocorticoid actions have on the body. The mineralocorticoids, predominantly aldosterone, are also secreted by the adrenal cortex under the control of the RAS system. And the main role of aldosterone is to retain sodium in water and to excrete potassium. So glucocorticoids or corticosteroids, when we prescribe them, are well absorbed from the GI tract and metabolized in the liver, and excreted in the kidneys. These are some of the precautions, which are many. They're contraindicated in patients that have active, untreated infections, patients with hypertension and cardiovascular disorders. It can be a real issue because they elevate blood pressure, cause salt and water retention, and cause increased excretion of potassium. So you can imagine the numerous problems with cardiovascular patients. And they should be used cautiously in postmenopausal women because they're already at risk for osteoporosis, and corticosteroids can cause or exacerbate osteoporosis. Patients with diabetes will notice a decrease in their glycemic control, and sometimes it can precipitate. If you have a patient who unknowingly may be pre-diabetic, will have diabetic levels of glucose when you give them corticosteroids at times. Ulcerative colitis or peptic ulcer disease, caution with them because they are going to have an increased risk of GI bleed and even perforation. They can cause skin atrophy. A person can actually have increased hair growth while on corticosteroids. I did see this in a patient who was given a Medrol dose pack for poison ivy, and it wasn't effective, and I never used the 5-day Medrol dose pack for poison ivy for this reason. she kept having rebound symptoms and ended up on steroids 3 times in the space of a month, and she started to grow hair on her face. It can cause muscle atrophy. We actually see that skin and muscle atrophy when we use injections of corticosteroids. But also truncal obesity, buffalo hump, and moon facies are typical in patients on long-term corticosteroids. And as I mentioned, osteoporosis, up to 20% of patients may develop osteoporosis. So they may be need to be treated for osteoporosis, even if they had not been, when they start long-term steroids to prevent this. Other adverse reactions include cataracts. That's well known to be concerned about in long-term steroid use. Peptic ulcer disease was also mentioned in cardiovascular as well. Central nervous system changes, delirium, agitation, insomnia, mood swings, and depression. Endocrine system, we know that it can cause adrenal suppression, and withdrawal can occur if they're abruptly stopped. So we always taper, and it also, as I mentioned, affects glucose metabolism. Other drug reactions that can occur with even short-term use, patients are at increased risk for sepsis, VTE, fracture, and avascular necrosis, although that may be rare. But in a large national data set that looked at short-term use, these risks were actually significant, and they generally occurred within 5 to 30 days after the corticosteroids were initiated. In this study, the more common side effects were hypoglycemia, elevated blood pressure, an immunocompromised state, mood and sleep disturbances, and fat necrosis at the injection site if it was an injection. The next few slides will go into indications and dosing for corticosteroids. So in primary adrenocortical insufficiency, glucocorticoid and mineralocorticoid properties are lost, but in secondary, the mineralocorticoid function is preserved. In the US, primary insufficiency is an uncommon disorder, but widespread use of corticosteroids in patients for multiple reasons has led to secondary adrenocorticoid insufficiency being much more common due to steroid withdrawal. The key to treatment of primary or secondary disease is replacement of the missing hormones. So the drugs of choice are hydrocortisone, cortisone, and prednisone because each of them has both glucocorticoid and mineralocorticoid effects, so they require no additional mineralocorticoid, and these are the dosing options that you have. In a patient with inflammation, we can use methylprednisolone, prednisone, and triamcinolone, or dexamethasone. And any of these can be used to reduce or prevent inflammation. Because the need for mineralocorticoid activity is low or absent in the indication of inflammation, drugs with more anti-inflammatory activity are appropriate, and that's what these are. But for immune suppression, we can use prednisone. It has a short half-life. And although all corticosteroids have immunosuppressive capability, prednisone is the most commonly used. It is, as I mentioned, short half-life. It is very low cost. There's negligible mineralocorticoid activity, and it's also available in 5 and 20 milligram tablets that make dosage changes really simple for patients to manage in the long term. For post-transplant immunosuppression, there's often a need for a combination of immunosuppressants, and high-dose corticosteroids are generally used together. For rheumatoid arthritis, the mainstay of therapy is DMARDs and biologics. However, so when we go to choose corticosteroids, we need to look at the length of therapeutic action that's needed as well as relative potency. And short-acting agents are less likely to produce HPA axis suppression. Examples of short-acting are cortisone tablets or hydrocortisone or Solu-Cortef. Intermediate acting examples are methylprednisolone, prednisolone, and prednisone may actually be considered intermediate to, or short acting to intermediate. And then long acting examples are betamethasone and dexamethasone. And they're preferred if the effects of high doses need to be sustained over a period of time. If the patient has adrenal insufficiency, you need to use one with mineralocorticoid activity, but not if inflammation or immunosuppression is needed. So these are some of the principles of prescribing corticosteroids. Daily doses are best taken in the morning before 9 a.m., and that's because you need to match the natural body rhythm. And we know that maximum activity of the adrenal cortex is between 2 a.m. and 8 a.m. Secondly, the initial dose depends on the specific disease being treated. So you need to maintain or adjust the dose until an acceptable response is achieved. After an acceptable response is achieved, you need to determine the maintenance dose. The maintenance dose is going to be determined through tapering. Tapering until the lowest dosage that maintains an adequate clinical response is reached is what you need to do. And if after a long-term therapy or because of spontaneous remission, the drug is to be stopped, taper off to prevent adrenal insufficiency crisis. So tapering is generally not necessary after short-term therapy, but when you have long-term therapy, you definitely need to taper over a long period of time. And that may be dependent on how long the patient's been on the dose to be, the prednisone. For example, a patient that has polymyalgia rheumatica will be on long-term steroids for generally about 2 years until, that's the natural course of the natural history of the disease. And so over that long period of time, you're going to taper off very slowly. And fifth, most conditions that require chronic corticosteroid therapy can be well controlled on an alternate day therapy. So unlike using a tapering schedule, alternate day scheduling retains the same total steroid dose. You use twice the daily dose every other morning before 9 a.m. Unfortunately, at least in primary care, we're seeing too many, I think, short-term oral steroids being used for conditions that can be treated in other ways. And so in this slide, you can see conditions that we have no evidence for the appropriate use of oral steroids: sinusitis, rhinitis, allergic rhinitis, adhesive capsulitis, like the shoulder, bronchitis, carpal tunnel syndrome, plantar fasciitis. Some of these can be used with, treated with topical or injectable steroids, like for plantar fasciitis, adhesive capsulitis of the shoulder. Now, in the case of bronchitis, if a patient has acute bronchitis that actually has underlying asthma or COPD, then it would be indicated, if the patient is wheezing, has evidence of bronchospasm, to use short-term steroids. There is some evidence for using short-term steroids for shingles, radiculopathy, and pharyngitis. I've seen way too many people, though, being given steroids for low back pain who don't have radiculopathy. But if you give steroids in patients that have radiculopathy, they may have improvement of function, but not in the level of pain control. It usually is not enough to, for pain control, and so other modalities need to be used. For shingles, you're not going to, you can use steroids, but use them with antivirals, not in place of antivirals. There's better evidence for the use of short-term oral steroids for patients that have Bell palsy, and in that case, short-term use is definitely the recommended use. Also with gout, you could have equal efficacy with indomethacin, but less gastric side effects if you use short-term steroids. So I think my point here is to be aware that these are some uses of oral steroids, but we need to really be judicious about our use of steroids, because the side effects are just not worth these short-term benefits, at least in certain conditions. So these are symptoms of adrenal insufficiency that we can see from exogenous long-term steroids. Actually, we can see some of these from short-term steroid use because we know that the HPA axis can actually be suppressed even after a single dose of steroid. Typically, it can recover quickly, but when you use steroids for longer periods of time, you may have some of these symptoms appear from adrenal insufficiency. So typically the hypothalamic pituitary axis, adrenal axis, recovers after cessation, but the timing of recovery can be variable and can take anywhere from 6 to 12 months. And so often the patient is off these steroids for a long period of time and may be having some of these vague symptoms that are not actually identified as adrenal insufficiency. Now we'll discuss some of the monitoring that we need to do. Of course, at baseline and ongoing, we're looking at the patient's weight because we know for long-term use, we're going to see an increase in that. Effect of electrolytes, glucose, as I mentioned before, a CBC. Long-term or high-dose therapy, we do need to monitor for GI bleeding. We need to look at the effect on the lipids. And we need to make sure the patient has a regular eye exam to detect cataracts or glaucoma that can occur in long-term therapy. Patient education, of course, we need to talk to them about how to take them. Long-term steroids, they need to be very careful about taking them the same time every day, in the morning. If they're on an alternate day or tapering dose, they need to really understand that, and they need to know that they cannot abruptly stop steroids. Now we'll talk about NSAIDs. NSAIDs are primarily used for pain, fever, and anti-inflammatory activity, as you know, and they can reduce the need for opioids. But they are the most commonly prescribed prescription and over-the-counter drugs, and we need to be concerned about side effects for NSAIDs. I've often said that they should be taken off the counter just because of the ways that they can be abused by patients. This diagram shows the action of NSAIDs, and although the exact mode of action is not really known, we do know that the major mechanism is thought to be inhibition of cyclooxygenase activity and prostaglandin synthesis. The inflammatory response is the same regardless of injury. So this shows what happens in the inflammatory process, where we start with destruction of cell membranes, which results in the release of chemical mediators, which include histamine, prostaglandins, leukotrienes, etc. And then two major enzymes are required to produce these mediators, lipoxygenase and cyclooxygenase, or COX. COX is an enzyme which produces prostaglandin H2 from arachidonic acid, and the two cyclooxygenase isoenzymes that have been identified are COX-1 and COX-2. COX-2 inhibitors were developed to decrease GI bleeding side effects. However, back in around 2004, two of them, Vioxx and Bextra, were taken off the market because of their increased cardiovascular risks. So the NSAIDs can inhibit COX-1 and COX-2 activity, thus inhibiting prostaglandin synthesis. COX-1 is present in all tissues and cells, and COX-2 is synthesized mainly in response to pain and inflammation. Absorption is rapid after oral administration. Absorption can be affected by food. It can be delayed by food, but that does not affect the total amount that will eventually be absorbed. And metabolism of all NSAIDs is by the liver, and they are excreted in the urine. Most common adverse reaction is GI disturbances, and we do instruct the patient to take them with food to reduce GI upset, even though that will delay absorption. And we do need to monitor for ulcers and GI bleed. Acute renal insufficiency can occur with NSAIDs, And that is something to really consider. And of course, a patient that has renal insufficiency should be instructed never to use NSAIDs. Indomethacin can aggravate depression or other psychiatric disturbances, and caution in pregnancy, especially in the first trimester. They can inhibit platelet aggregation and may increase bleeding time. But NSAIDs are not used for the purpose of inhibiting platelet aggregation for cardiovascular disorders because the effect is only while the NSAID is in the blood, and it can be very short-lived, quickly reversible. So they're not used for that purpose, but they can increase bleeding time. Fluid and retention and peripheral edema can exacerbate heart failure, increased risk of thrombotic events, elevation in arterial blood pressure. COX-2 inhibitors and all NSAIDs have a black box warning, so we still have Celebrex, which is a COX-2, on the market. And they all have black box warnings for cardiovascular risk, so they can all increase the risk of heart attack or stroke. The risk of NSAID-mediated blood pressure increase in patients who are on drugs for controlled hypertension, to control their hypertension, depends on the antihypertensive they're on. So especially with beta blockers and RAS inhibitors, then the increased blood pressure risk of NSAIDs is more prevalent. The level of risk displays, a large variability between individual drugs in the group, and that seems to be affected by baseline cardiovascular risk in patients. Although cardiovascular adverse drug reactions can develop even in individuals who do not have a pre-existing cardiovascular condition. Keep in mind that many patients with hypertension have other comorbidities such as diabetes, also have renal insufficiency. So you really want to make sure that you're not adding insult to injury by giving them NSAIDs for some minor pain or inflammation. Generally, we recommend Tylenol for patients with renal insufficiency and instruct patients to avoid over-the-counter NSAIDs of all kinds. Okay, this slide talks about, we're going to get into the indications and dosing of for NSAIDs. Rheumatoid arthritis. Keep in mind that most patients with severe rheumatoid arthritis and osteoarthritis are elderly and often have comorbidities, as I mentioned in the previous slide. So hypertension, and they're often on antihypertensives. So we really want to be careful about using NSAIDs in this population. There are recommendations to the American College of Rheumatology. I briefly mentioned when I talked about corticosteroids with rheumatoid arthritis that we want to use DMARDs, and that is disease-modifying anti-rheumatic agents. And we may use some steroids or NSAIDs along with those, but we need to be very careful in these patients. And these patients, even with just having rheumatoid arthritis, they're going to have renal involvement at some point, so we need to be particularly careful in them. Osteoarthritis, again, these patients tend to be older adults, and so we want to push acetaminophen rather than NSAIDs as much as possible. Gout, typically we can use indomethacin, naproxen, or Soldenac. For mild to moderate pain, we can use non-opioid analgesia such as NSAIDs and acetaminophen. Usually ibuprofen and naproxen are the most commonly used. Those are available over the counter, and patients often treat themselves. Primary dysmenorrhea, ibuprofen or naproxen are the drugs of choice. We can use indomethacin, naproxen, and Soldenac in tendinitis and bursitis. And for fever, ibuprofen seems to be the best antipyretic. As I have certainly made clear, renal function needs to be monitored, especially in long-term therapy, and we need to monitor for GI bleed or ulcer symptoms. We may need to check a CBC. It could be an insidious loss of blood over a long period of time. And acetaminophen if we're using that instead of NSAIDs, we may need to monitor liver function, but usually only for very high dose or long-term therapy. Now we'll talk about aspirin and non-acetylated salicylates. So aspirin, salicylates, these drugs have analgesic, anti-inflammatory, antipyretic, and antiplatelet activities. And the anti-inflammatory and analgesic activities are mediated through inhibition of prostaglandin synthesis, just like the NSAIDs. But aspirin is a good inhibitor of platelet aggregation. And so it has many uses, and we often use this for patients at risk for clotting. Aspirin is rapidly absorbed and completely absorbed after oral administration. Food can slow absorption, as with the NSAIDs, but it's widely distributed to all tissues, metabolized by the liver, and eliminated in the urine, just like the NSAIDs. The urinary pH can influence excretion. We need to be concerned about many of the same things as with NSAIDs, GI irritation, ulcers, bleeding, iron deficiency, anemia. It can be ototoxic at higher levels, so patients can present with tinnitus. We avoid use of aspirin in children or adolescents because of the risk of Reye syndrome. Avoid after surgery because of bleeding risk, and avoid in pregnancy, in this case, especially in the third trimester. I do want to mention aspirin poisoning. Lethal dose in adults is between 10 and 30 grams, and patients develop respiratory alkalosis. So in treatment, we induce emesis or do gastric lavage to remove any of the unabsorbed drug. If it's less than 2 hours and it's still in the stomach from ingestion. Alkalinizing the urine may increase excretion, but hemodialysis may be needed for severe poisoning. So indications, obviously fever. It's a very effective antipyretic. We don't want to use it generally in pregnant patients or children. Mild to moderate pain. It is the gold standard for pain management. For rheumatoid arthritis, it can be a gold standard, but there's also a narrow range between a good therapeutic level and toxicity when we're treating patients with rheumatoid. Juvenile rheumatoid patients will often be given advice to take aspirin as well. And for osteoarthritis, it does work well for treatment of pain. We do use aspirin for myocardial infarction prophylaxis, so daily treatment is generally with low dose of 81 or up to 325 milligrams of aspirin, and that's been associated with a 20% reduction in reinfarction. At the first sign of an MI, patients should take one 325 milligram aspirin tablet, and we also can use it for TIAs. And I do recall as a child actually observing my grandfather, who in retrospect I know was having a TIA, and this is some probably 45 years ago. And the first thing that my grandmother thought to do was to give him an aspirin, because aspirin was considered the drug for all purposes. And in retrospect, it's just interesting to me that she actually gave him the exact right thing, because it could have actually done something to prevent stroke. We do want to monitor renal function, a CBC, and consider fecal blood testing because of the adverse drug reactions we can have with aspirin.